morning. Thank you for the kind invitation to speak. How do I advance? Okay. Okay. That's good. All right. These are my disclosure. The only relevant disclosure to this presentation is funding from Patient-Centered Outcome Research Institute for a clinical trial looking at conduction system pacing that we'll discuss at some point during the presentation. So today we'll touch up on a couple of questions: why, how, what technique, and who and when to use conduction system pacing. So let's review the clinical scenarios that where ventricular pacing is relevant. So based on the level of conduction system disease, at the level of AV node or his bundle, you may have prolonged PR, high degree AV block, or atrial fibrillation with either AV node ablation or slow ventricular rate. This typically will result to high degree of ventricular pacing. When you have intra or infrahisian disease, you have left bundle branch block, right bundle branch block, or IVCD, which we frequently use cardiac resynchronization therapy achieved by ventricular pacing. So again, depending on the level of disease as well as the ejection fraction, you may use either a pacemaker or cardiac resynchronization therapy. So let's review briefly the data and what are the limitations with standard pacing strategies. So we know from multiple clinical trials, randomized clinical trials done in over 8,500 patients, that biventricular pacing improves survival, reduces the heart failure hospitalization, improves quality of life and exercise capacity in patients with ejection fraction less than 35% and the wide QRS. Now, unfortunately, as seen in this graph, there is a significant number of patients that do not respond to biventricular pacing, anywhere between 20 and 50%, depending on what measure you use for response to biventricular pacing. So that's a limitation that we like to improve on in this particular patient population. Now, looking at the intermediate ejection fraction, we know from block HF that biventricular pacing is superior to RV pacing in a combined endpoint of death, heart failure hospitalization, and an index of left ventricular remodeling, mostly driven by the later two. Again, unfortunately, this is not as much used in outside of US. In many countries, they still use predominantly RV pacing for this patient population. And then finally, we know from David and Moss that with RV pacing seems to be detrimental. It can lead to heart failure, and there seems to be a correlation between the degree of RV pacing and the incidence of pacing-induced cardiomyopathy, and that seems to be around 40% RV pacing. So again, our goal is for ejection fraction less than 50%, where you have already cardiomyopathy and usually either a wide QRS or high degree of RV pacing, is to reverse LV electrical and mechanical dysynchrony and hopefully reverse the cardiomyopathy. For patients with normal ejection fraction that require a high degree of RV pacing, would like to prevent LV electrical and mechanical dysynchrony due to RV pacing and potentially prevent the cardiomyopathy. So just briefly summarizing based on the data what the indication for biventricular pacing is, without going into the details of the New York Heart Class or QRS duration and or or the conduction system pattern, by and large, in patients with less than 35% biventricular pacing, it's indicated for QRS greater than 120 milliseconds, again, with caveats depending on the actual underlying conduction system disease. And then in special situation include high degree of RV pacing and atrial fibrillation, where you have slow ventricular rate, or you plan rate control with AV node ablation. In the 36 to 50% range, the only indication for infrahisian disease is left bundle branch block with QRS duration greater than 150 milliseconds. And then similar situations, special indications include high degree of RV pacing or atrial fibrillation with planned with slow ventricular rate or planned AV nodal ablation. So now the question is there anything better? And in essence, we've known for several years that his bundle pacing, it's an alternative, and we'll discuss some of it now, why it's has fallen out of favor somewhat. But in 2019, Weijuan Huang and colleagues have published a case report that was done in a patient with left bundle branch pacing. In essence, this patient had a non-ischemic cardiomyopathy, low ejection fraction, and they were unsuccessful to deliver a CS lead. And they screwed the lead deep into septum and captured the left bundle. And within a year, the ejection fraction in this patient improved. There was a significant left ventricular remodeling, as illustrated by decrease in the left ventricular and diastolic diameters, BNP improvement in New York Heart Association class, and importantly, the threshold, pacing threshold was preserved at 1 year. So let's back up a little bit and look at the conduction system. The AV node, it's an atrial structure. Then you have the penetrating bundle. And as you can see, his bundle, it's a fairly small structure, and it's encased in fibrous tissue. So one could understand why his bundle pacing has been quite challenging to achieve. And importantly, if you end up in this area, if you lose capture of the left bundle, then you don't have any backup capture, right ventricular muscle capture. So basically, if patient has complete AV block and you lose capture, then there will be potentially asystole. Now, the left bundle, you can see it's a much wider structure. And the distribution of the fascicle, you can see a wide, rich network of his Purkinje fibers that also follow distribution of the papillary muscle. So that suggests that, in fact, left bundle area pacing may be a more accessible technique. You have a much larger area to capture. And secondly, if you do lose conduction system capture, you still have right ventricular capture. Now, if you look at the distribution of the activation, here it's experiments from 1970s in hearts explanted for patients with cerebrovascular death that were implanted with up to 870 electrodes at different location and depths. And you can see the activation occur on the left side of the septum and follow the distribution of the fascicle. So typically you have early breakouts by the left anterior left posterior fascicle, and sometimes a septal fascicle. And then there is rapid activation both endocardially and toward the epicardium of the left ventricle. And the latest area that's activated is the basal left ventricle. So that results in a shortening of the apical basal axis with the torque of the apex, and the final portion that squeezes is the basal left ventricle. And that it's a very effective way to generate cardiac output. Another thing that it's important to emphasize is that this work from Rotang and Gaurav Upadhyay at University of Chicago is that, in fact, when we classify left bundle branch, some of the disease, as illustrated here, actually occurs intrahisian. So there are fibers that are already committed to the left bundle, and in fact, that's why we see sometimes when we screw a lead in the his bundle, we can actually correct left bundle branch block. And they've noticed that, in fact, 46% of the left bundle branch patients have infrahisian block in the fibers that are committed to the left bundle. So now, with this background for conduction system anatomy and physiology, let's briefly talk how left bundle branch can be accomplished. So here in RAO, if you do have, if you still have preserved conduction through the His bundle, ideally you would like to map the His bundle, and then on an imaginary axis that connects with the RV apex, you would go about 1 to 1.5 centimeters. And in LAO, you like the, this is usually accomplished with septal sheets that direct the lead toward the septum, and you like the tip of the lead to be pointed toward 1, 2 o'clock. And particularly with lumenless leads, you like to do rapid torquing of the lead so that you can generate PVCs, and as you screw it in, you are going to see the morphology changes from a left bundle to a right bundle. And when you see that, you slow down and pace at different depths and gradually torque it more until you obtain the desired location, and then you can use a number of criteria to establish whether you have conduction system capture. There is not great degree of agreement on what are the best criteria, but I think based on current knowledge, probably this is the best outline that was recently published by ERA, and that's what I use in my practice with some degree. So one criteria is to observe transition either from non-selective left bundle branch block to selective left bundle branch block, or from non-selective to left ventricular capture. So as you decrease the output, you are going to see a transition, and that will suggest that you did capture the left bundle area pacing. Next criteria, if you can see that, sometimes the effective refractory period of the ventricular muscle and conduction system may be quite similar, so you may not observe that. Then you can use the peak activation time in V5, V6, and the most specific is if you use 75 milliseconds cutoff, and for a native narrow QRS, and 80 milliseconds if you have left bundle branch IVCD or right ventricular or wide escape rhythm. Then you could use the inter-peak interval, which as you screw the lead deep, basically you activate the lateral or sooner, but you have some delay in activation of the right ventricle, and that's the basis of that. And if that doesn't work, you could use extra stimuli. And if none of these criteria are met, then there are loser criteria where it's suggested maybe likely left bundle branch block, but if none, you cannot meet any of these, then by default it becomes left ventricular septal pacing. In terms of techniques, all the device company makers have developed sheets to target the left bundle area pacing. And here you have example from each one of them. They have a slightly different curve, so it's good to have ideally in your armamentarium all of them in case you have to adjust different anatomical conditions. And similarly, each company has leads that have been tested for left bundle pacing. So many of you are familiar with lumenless lead from Medtronic, but there are a number of stylet-driven leads from each one of the companies. In fact, Abbott has 2 leads now. Now, let's go on over the evidence on why conduction system pacing may be a good idea and potentially a good alternative to what we are doing these days. So here is an example of a patient with narrow QRS. This is ultra-high frequency EKG. It's additional leads, precordial leads, and faster sampling of the EKG. And what you can observe here, when you have a narrow QRS, basically the lateral wall, the interventricular septum and the RV wall are activated nearly at the same time. Furthermore, if it occurs through the conduction system, the width around this midline represents the conduction velocity. So you have very fast conduction velocity, right, that occurs through the conduction system. It's about almost 10 times greater than the ventricular conduction. Now, if you look at the left bundle branch block, you can see that the lateral wall it's activated much later with this electrical desynchrony index 120 milliseconds. And the other thing that you observe here is the band around the midline. It's much wider, which suggests the conduction proceeds with a much lower velocity. Now, when you do left bundle branch pacing, here is an example where you while you screw the lead deeper and deeper in the septum and you monitor both the QRS morphology changes as well as do ultra-high frequency at different depths. Again, you can see that as you screw deeper and deeper, the morphology changes from a left bundle to right bundle branch morphology. And initially you have desynchrony toward the lateral wall. And interestingly, when you get deep enough, you actually get the narrowest QRS, and you know it seems like all it's activated almost at the same time. Albeit the conduction, as you can see, the band here, it's much wider. So that suggests the conduction proceeds slower through the muscle. But as you capture the left bundle branch block, you can see that now you resynchronize the lateral wall of the ventricle, this band that estimates the conduction velocity is very narrow, but the QRS, it's wider than when it was deep septal, right? Because now you activate the right ventricle with delay, so you introduce interventricular desynchrony. And we don't know whether that's significant from a clinical standpoint, but there are a number of studies that are ongoing. So here are examples from 2 of my patients, his bundle pacing. This is the kind of electrographic or electrical resynchrony that can achieve. So a patient that had RV pacing with a pace QRS of 190 milliseconds, complete heart block, developed cardiomyopathy, and we then placed the his bundle lead and we narrowed the QRS selective his bundle conduction 82 milliseconds. The ejection fraction improved from under 35% back to normal, and with significant improvement back to normal of exercise capacity. Here is an example of left bundle branch pacing a patient with left bundle branch at baseline QRS duration of 142, non-selective left bundle with QRS of 100 milliseconds, and significant improvement in ejection fraction and exercise capacity. So what's the evidence for conduction system pacing? So there are about seven randomized clinical trials. Unfortunately, they're all underpowered, short follow-up, and usually surrogate endpoints. But in general, the conclusion is for his bundle, it's difficult to achieve. There is a high crossover rate when compared with biventricular pacing, and very good electrical desynchrony, but not sufficient follow-up to determine whether that results in improved outcomes. There are a number of retrospective studies of various sizes, and we'll discuss a few of them to illustrate some of the potential results we may expect from conduction system pacing. Not so much in the mid-range ejection fraction, neither from randomized clinical trials nor from retrospective data. So again, to illustrate, HeSync clinical trial, again done by Rotang and Gaurav Upadhyay, high crossover rate, definitely improved QRS duration and echocardiographic response. Again, small study, so no outcomes there. We have large prospective and some retrospective database out of Europe that involved 2,500 participants from 14 centers. And what this again shows improvement, the success rate for bradycardia was higher than for heart failure, which suggests there are maybe some interventricular septum scarring that may prevent or diminish the success. Overall, the complication rate cited in this publication is the highest of all, but you can see that a lot of it is from acute LV perforation, which can be corrected right away without any apparent long-term issue. So you recognize it, you withdraw the lead and implant it in a different location, and it doesn't seem to cause a problem. This is one of the largest retrospective studies comparing left bundle, mostly left bundle area pacing with biventricular pacing in patients with ejection fraction less than 35%, 15 international centers, including Baylor. And there was decreased combined endpoint of death and heart failure hospitalization with conduction system pacing compared to biventricular pacing. Obviously, there is some bias in all the retrospective studies, but this is, promising. When you look at secondary endpoint, which is basically the individual components of the primary endpoints, mortality was no different. The endpoint was driven by heart failure hospitalization. And similarly, when you look in patients that had left bundle branch block at baseline, decreasing heart failure hospitalization, but no change in mortality. We also did a sub-study and looked at ventricular arrhythmias, ventricular tachycardia, and ventricular fibrillation. And you can see there is a significant decrease of ventricular arrhythmias with conduction system pacing, left bundle branch pacing compared to biventricular pacing. And Similarly, in patients without any prior history of VTVF or antiarrhythmic therapy, again, significant decrease there. And looking at new onset atrial fibrillation in this population, there was less atrial fibrillation in patients with left bundle pacing compared to biventricular pacing. We conducted a meta-analysis combining all the published studies, both smaller randomized clinical trials and retrospective data, and it seemed there is a significant decrease of all-cause mortality with conduction system pacing, heart failure hospitalization. So all of these, some of this data actually was not available at the time when the new guidelines for pacing were published last year, but around the time of HRS. But in essence, now conduction system pacing has been introduced in guidelines as an alternative to biventricular pacing. And obviously, the level of evidence is lower, but certainly any time when biventricular pacing is indicated and you fail to deliver a CS lead, conduction system pacing, it's an accepted alternative. And in certain situation, you could use it from the get-go as an alternative to biventricular pacing after a discussion with your patient. So again, you can see here based on ejection fraction or underlying conduction abnormality that basically for an indication, left bundle pacing may be used. So now, obviously, as I mentioned, as I alluded, a lot of the retrospective data definitely has some built-in bias, selection bias and other biases. So the future is to try to get better quality data from randomized clinical trials. And the good news is that there are a number of moderate to large clinical trials in different patient populations that hopefully will give us an answer whether conduction system pacing is equivalent or better than biventricular pacing, or in certain cases than right ventricular pacing. So here you can see 3 clinical trials dedicated to patients with ejection fraction less than 35% and left bundle branch block. All of them are ongoing. Brazilian one, as of August, they enrolled at least 100 patients. In Spain, they enrolled 100 patients as of November. So we'll hopefully have some data soon. For mid-range ejection fraction or normal ejection fraction with expected high RV pacing burden, Canadian trial, they had the feasibility phase. They already passed that, so they are now in the full scale trial. Largest trial is out of UK, 2,600 patient. Optim pacing, it's ongoing. I think they passed over 300 implants. We are a center for that. And then one question is, I've shown with the ultra high frequency EKG, it's interesting that even with deep septal pacing, it seems to, at least by ultra high frequency, that you achieve quite a bit of resynchronization. So this clinical trial is looking at left ventricular septal pacing against RV pacing in Netherlands. And then finally, one of the larger trials, as you can see for mid-range and normally EF, most of the trials are designed against right ventricular pacing. However, in United States, in this mid-range, we mostly use biventricular pacing. So our own trial versus left compares conduction system pacing with biventricular pacing in the entire population that qualifies according to the current guidelines for biventricular pacing. So Ken Ellenbogen and I are leading this trial that will involve 2,136 patients in US and Canada, and stratified by ejection fraction or less than 35% will randomize to biventricular defibrillator versus defibrillator with a His or left bundle pacing lead. And for ejection fraction between 36 and 50% will randomize to biventricular pacemaker to dual chamber pacemaker with a His or left bundle lead. The primary outcome is death or heart failure hospitalization. Primary safety outcome is percent of complication, and the funding is from Patient-Centered Outcome Research Institute. The study is two-phase. Feasibility phase included enrolling 60 patients with 10 centers. We completed that 4 months ahead of schedule. So we are now moving toward the full-scale phase where we would activate all the sites. We hope to enroll all the patients in 2 years and follow up from the last patient enrolled for at least 3 years. So final thoughts, for ejection fraction less than 35%, we have a very solid data for biventricular pacing. There are small clinical trials, so we don't know the outcomes, but the retrospective data certainly looks very promising. There are a number of ongoing trials that will hopefully give us an idea on relative effectiveness of the two pacing therapies. And then there is certainly a healthcare economics which will determine, where the needle will go, depending both on the efficacy, but also on the cost. So as you, if the effectiveness is similar, potentially with the conduction system pacing, you may have less hardware. The ICD can, it's less expensive than a CRT can, and certainly the His or left bundle pacing lead, it's less expensive than a quadripolar lead. For the mid-range, we have less evidence for biventricular pacing, virtually not much data, for retrospective data, but there are a number of large clinical trials. Unfortunately, most of them against RV pacing, with the exception of left versus left. And again, the economics are favorable too, if they're equivalent, I think, particularly in developing countries, because you have less expensive CAN pacemaker versus CRTP and one less lead that may tilt the needle toward conduction system pacing. Thank you. That's all I had.